Hi, everyone. Today we're going to talk about a critique of the YMCA's diabetes prevention program for type 2 diabetes, which is a chronic condition that I'm sure many of you know has major public health impacts. Currently, it affects more than 37 million Americans, and then 90 to 95% of that 37 million have type 2 diabetes. That equates to around an 11% prevalence. And importantly, and we'll revisit this later, 1 in 5 of these cases are undiagnosed. So diabetes is not only vast, it has significant adverse public health outcomes. Not only is it a major leading cause of death, it's seventh in the United States. And not only does it come with an incredibly high cost of care for the overall health system and for individuals. Here you can see those with diabetes spend twice as much on their health care. But most importantly, it's associated with a higher risk of some incredibly life-threatening and disabling diseases. So heart disease, stroke, high blood pressure, kidney failure, mental health challenges like depression, and then lots and lots of disability. So things like amputation, blindness, and it impacts activities of daily living and physical mobility as well. So what are the risk factors? Older age, race and ethnicity, having a family history. A big one is having a BMI that qualifies you as overweight or obese, low physical activity, cardiovascular disease risk factors, having prediabetes. And then there are some social determinant risk factors like a low income status or being less educated. So all of this means that higher risk populations tend to be the elderly, the less educated, minorities, low income folks, those with a family history, women with gestational diabetes, as well as those living in the southeastern United States, states like Alabama, Louisiana, Mississippi, Kentucky. So it's also important to note that type 2 diabetes has some glaring health disparities, meaning that these folks experience a higher prevalence, incidence, and mortality and morbidity rates as compared to the general population. And for type 2 diabetes, that mainly means class, so those who are less educated and who have a lower income, and also certain racial and ethnic minorities, namely the American Indian, Alaskan Native population has an extremely high prevalence rate, as well as African American populations. So what are we doing about that type 2 diabetes? Well, there's a large network of primary, secondary, and tertiary interventions. And the one that we're going to be looking at today is the YMCA's intervention, which is an adapted version of the CDC's diabetes prevention program, which is a national program that is meant to be rolled out in communities and scaled. And the YMCA's version sticks pretty closely to the CDC's version. There are some adaptations, which we'll talk about in the next slide, but it upholds the program outcome goals, which are to have participants achieve a 7% weight loss of their initial weight and to do at least 150 minutes per week of physical activity. And then there are some kind of secondary diet goals and behavioral health, like absence of tobacco use. And it does this through a lifestyle intervention that uses behavioral self-management ideas. So things like goal setting and skill building to achieve diet and physical activity change. This program is importantly targeted at an eligible population of adults who are overweight and who already have prediabetes based on diagnosis or are considered high risk based on a number of eligibility factors. And it's delivered as a 1-year program. It has 25 1-hour small group sessions led by a trained YMCA lifestyle coach. And then after the core curriculum, there are 2 supervised exercise classes at the Y each week that people can attend if they'd like. So this has been incredibly implemented at more than 200 Ys across the nation, served as of 2017, more than 14,000 individuals with 1,500 lifestyle coaches participating, which is pretty impressive. And the adaptations are the fact that these lifestyle coaches lead these sessions in a group setting rather than healthcare professionals leading these sessions on a one-to-one basis. And then there are also some small curriculum content modifications to reflect the local culture and infrastructure of each Y. But for the most part, the curriculum is kept the same because in order to get the DPP certification, that needs to be the case. So Some of these local YMCA programs have been evaluated. The most popular is the Deploy evaluation, which took place in Indiana. And that found that not only was the program feasible as an adaptation, but that it achieved clinically significant outcomes, specifically the percent change in body weight between an intervention group and a control group. So what does all of this mean? The first is that this is a great example of a community-based adaptation of a national program that is evidence-based and that has been proven to work, and that has resulted in a 58% chance of decreasing the risk of type 2 diabetes. It also is an adaptation that has made significant strides in improving cost and scale. Whereas the DPP was cost prohibitive, the WISE program has used salaried employees and also delivered a cost to individuals that's made it affordable, and it's scalable based on their national infrastructure. The Deploy evaluation and some others also showed it to be feasible and achieved with fidelity, as well as having clinically significant impact and outcomes. So all of that's really great. But as always, there are some opportunities for improvement. One is that the eligibility requirements are limited. As we know from slide 1 in 5 people don't even know that they have prediabetes or that they have type 2 diabetes. And so when you require that in order to be eligible, it means that 20% of the population you should care about isn't even able to start to participate. So that is something that could be improved. This is also an individual level program only. It doesn't focus on any of the environmental determinants that we know are important risk factors for diabetes. So even though the Y goes out of their way to make their programs available to anyone of any income status, those who do have access to Ys, both in terms of their time, their transportation, and their money, will likely fall into a certain category. And so this is a program that isn't impacting the kinds of risk factors that we know to be important, and it's not necessarily addressing a lot of the groups affected by health disparity. And then finally, although this program has been implemented for some time, there isn't really a long-term outcome or impact evaluation on record. And so in order to keep improving a program and to even get more funding, these are two really important things that need to be done in order for something to continue to be successful. So all in all, this is a fantastic program, but there are some things that could be done to improve it. But it's a great example of an adaptation, and that's been made to be scalable. And it's exciting that almost 15,000, probably more than 15,000 people, given the fact there are a few more years down the line, have been positively impacted. So here are some references, and thank you very much for listening.